Hi, my name is Brett Hockey. I am the Chief Medical Officer at Regis Hospital. The following video will go into detail about your role in implementing multiple safety initiatives and protocols here at Regis. We will explain why this is important for you and our patients. The video will include safety initiatives that comprise different safety priorities, including Clostridium difficile, central line associated bloodstream infections, catheter associated urinary tract infections, pressure injury, venous thromboembolism, hand hygiene, and antimicrobial stewardship. We view these as a collective responsibility in which all members of the care team work together to prevent harm. Additionally, these initiatives are key strategic priorities at Regis because not only do they influence patient care, but they have a financial and reputational impact as these are publicly reported measures. In 2015 and 16, Regis received financial penalties in the millions of dollars based on our publicly reported results in these measures. Given all of that, please take the time to listen closely to the information provided and think about how you will use this advice in your practices. So thank you in advance for your help in achieving our goals of zero harm for our patients. The following information will go into detail about what you need to know in order to adhere to these safety protocols.
Key information for you to know as a practitioner at Regis. To begin with, I will discuss C. diff. We are looking to identify those patients with C. diff while at the same time limit inappropriate testing because of the overly sensitive PCR test we use for testing for C. diff. In the first days of hospitalization, length of stay 0, 1, and 2, we're asking you to be more aggressive in C. diff testing. So if a patient has loose, liquid, or soft stools as a part of the presenting complaint, I would recommend C. diff testing. We would like to identify and isolate these patients as soon as possible. As a hospitalization is more prolonged, there are many other reasons for having diarrhea. At this time, we would like to be more selective in who we test. Literature has shown that 10 to 20% of the population is colonized, so testing based on clinical criteria is critical. If the patient has been hospitalized, length of stay 3 days or greater, you will see the following screen to guide decision making and will be required to have approval from the infectious disease physician on call for a C. diff review. Prior to reaching this route, the patient should have had greater than 3 loose stools in 24 hours. Also, we are looking to make sure the patient has been off laxatives for 48 hours and has indications for testing such as abdominal pain, high white blood cell count, or fever. We want to avoid over-testing and over-treatment in these patients who are merely colonized. If you are called by nursing for a patient with a length of stay 3 or greater, we expect that you will review the chart prior to ordering and not just agree to order based on the nursing recommendation. Each positive C. diff test is reviewed by the committee for appropriateness of testing. In our review of C. diff cases, our greatest opportunities are with antibiotic use and appropriate testing. We would like to reduce central line use at Regis. Please consider whether there are alternatives to a central line, such as a peripheral or midline catheter prior to placement. If there are questions regarding if a midline is right for your patient, please reach out to one of our PIC team nurses for clarification. We have a detailed insertion checklist that should be followed closely. The need for a central line should be reviewed daily. If considering a central line infection, please draw a peripheral blood culture and one from the central line. If the central line is needed, please consider the positioning and the likelihood of the dressing staying intact. If a central line is needed, avoid the femoral site. We would like to reduce urinary catheter use at Regis. Please consider removal at the earliest possible opportunity. Please note there are specific reasons for maintaining a catheter. Urinary catheters become colonized with bacteria at a rate of 3 to 10% per day. It has been shown that in an ICU patient, the urine is rarely the cause of a fever. I would recommend testing other sites first, such as the blood or obtaining a chest x-ray if clinical symptoms indicate. If a patient has localizing symptoms of a catheter-associated UTI, such as lower abdominal pain and flank pain without another cause, then consider testing. If testing for a cavity is undertaken, please change the catheter prior to collecting a specimen if the catheter has been in more than 48 hours. The appropriate order to select an epic is the UA conditional UC in most cases. If the UA has less than 10 white blood cells, then the culture will not be run. You will see the following order screen to determine if testing is indicated. If another source of infection is found, please cancel the urine culture. We would like to avoid overtreatment for a patient with urinary colonization.
Hi, I'm Dr. Rich Marr. I'm a hospitalist and the medical director for performance improvement and patient experience at Regents Hospital. I will be reviewing some key information for you as a practitioner at Regents. To begin with, I will discuss pressure injuries. Prevention of pressure injuries begins with a thorough assessment of a patient's risk. Risk factors may include limited mobility, a fall or being found down, a pre-existing skin condition, presence of medical devices, poor nutrition and hydration, incontinence, post-surgical state, limited alertness, extremes of weight, and impaired mobility. Hospitalization alone increases the risk for a patient to acquire a pressure injury. It is of great value to conduct a thorough skin assessment on admission and on transfer with documentation of existing injuries and discussion with the bedside nurse. Partnered bedside rounding with the patient's nurse can aid in identification, documentation, and treatment of pressure injuries. Let's ensure that we have an appropriate set of interventions in place for our high-risk patients. Interventions include providing appropriate surfaces under high-risk patients. For example, low air loss mattresses such as those on ICU beds and the P500 mattress overlay, which can be ordered for non-ICU patients. Additionally, optimizing nutritional support. Seek and heed the advice of our dietitians. Also, support nursing interventions by encouraging patients, families, and staff to accomplish frequent turning and early patient mobility. It is important to assess high-risk patients on a daily basis. When examining your patients, make sure they're not lying on cords, lines, or other objects. Pay careful attention to bony prominences, including the coccyx and sacrum, the occiput, elbows, hips, heels, and also examine skin around tethers and devices, including respiratory equipment, feeding tubes, and catheters, and known areas of skin injury. As providers, we should not be staging pressure ulcers ourselves, but we should document the existence of these injuries. Ideally, attempt to describe the location, size, color, presence or absence of drainage, and any plans that you have for treatment of the pressure injury. If you do see an area of concern, place a consult with a certified wound, ostomy, and continence nurse. Just type in wound nurse into an order entry field and you should see the order. Assessment early on is critical in capturing conditions present on admission to the hospital. It's our role to partner with our multidisciplinary team to facilitate early identification of pressure injuries, but also to decrease their likelihood of occurring in the first place through appropriate preventive care measures. Finally, when discharging patients who are in need of continued care for skin injuries, be certain to include instructions for wound care in the discharge orders. Select the wound care order in a discharge order set. Existing orders will be displayed, making this a fairly simple process. Thank you. Hospitalization alone increases the risk of venous thromboembolism, or VTE, 8-fold. Surgical and trauma patients are at particularly high risk. The incidence, though, can be reduced with vigilant prophylaxis. Prevention starts with having an understanding of risk factors and identifying and treating patients at high risk. Tools are available on admission and on post-op order sets for assessing risk. Caregivers working in teams of providers, nurses, and pharmacists can increase our chances of success by discussing risks of clotting and bleeding on admission and in a daily reassessment. Mobility is an important prevention measure. Please remember to place the appropriate activity orders on all patients and to update these orders as the patient's status changes. Also, when sequential compression devices, SCDs, or other mechanical means are indicated, Ensure that they are ordered and applied appropriately. This should be verified daily during bedside rounds. Thromboprophylactic medications decrease the incidence of VTE in high-risk patients. Please use order sets to guide the appropriate selection and timely administration of each of these medications. Once again, for each patient, reevaluate the VTE prevention plan on a daily basis. Finally, appropriate documentation is important to help avoid unnecessary financial penalties from insurers. Please document in the assessment and plan and in discharge summary the location of any newly diagnosed DVT. If a DVT or PE is present on admission, document it as such. And if a DVT or PE is found early in the hospitalization and you suspect it probably or likely was present on admission, please document it as probably or likely having been present on admission. That's it. Thank you very much.
Hello, I'm Dr. Becca Peglow, infectious disease physician and champion of antimicrobial stewardship work at Regents Hospital. I will be talking to you about the importance of antimicrobial stewardship, what the program includes at Regents, and what we expect from you. Antimicrobial resistance has been recognized by the Centers for Disease Control and Prevention and the World Health Organization as both a major public health issue and one of the 3 greatest threats to human health. Appropriate use of antimicrobials delays the development of resistance, and studies have demonstrated that requirement of indications on antimicrobials can decrease inappropriate use. Additionally, as of January 1st, 2017, the Joint Commission and Centers for Medicare and Medicaid Services have included antimicrobial stewardship. Based on all of that information, Regents has a formal antimicrobial stewardship program with goals of improving patient health outcomes, reducing antimicrobial resistance, and decrease unnecessary costs. The work for the program includes the following: performing patient-specific antimicrobial reviews, developing education material for healthcare providers, and enhancing reporting capabilities related to antimicrobial use. Antimicrobial stewardship services are available various days of the week with expertise from ID physicians and pharmacists. On these days, patients on anti-pseudomonal agents, vancomycin, and restricted antimicrobials are reviewed for appropriateness, safety, and efficacy by the antimicrobial stewardship team. If the antimicrobial stewardship team identifies areas of improvement, they may leave a note in the Dear Provider section of EPIC. If there are questions regarding recommendations provided by the antimicrobial stewardship team, please contact us for more information. We're listed under infectious diseases and AMION. Thank you.
Hand hygiene is the single most important thing we can do to prevent hospital-acquired infections. What you want to do is take a golf ball size amount of foam, rub it in on all your hands, including the digits, the web spaces, and your wrists. And you want to be rubbing it in as you go in to see the patient to assure them that we are taking care of their safety. Even if you're not planning on touching the patient, it's important that you still foam in because things could change and you may need to touch the patient or something in the patient's environment.
Good morning, Ms. Johnson. We're going to take a look at your wound this morning. Won't hurt at all. We're just going to pull back the dressing and see how it looks. Very good. Dr. Olson, would you like to take a look?
Yes, thank you. Looks good.
So we don't see any signs of infection. Everything seems to be healing up well. We're just going to replace the dressing here. Do you have any questions at all? Okay, well, have a good day. Dr. Olson, hands.
Thank you.
This concludes the video presentation about your role in prevention. If you have questions about this information, you can direct your inquiries to your attending medical director or any of us that were shown here in this video. Thank you for the work you do in keeping patients safe at Regents. Thanks.
Included antimicrobial stewardship as a condition of a participation based on.
The following video will go into detail. I'm going to start over.
Okay.
Continence, post-surgical state, limited awareness.